So we'll just give it one more minute or two just to allow for folks to join. I'm just trying to adjust my camera. Sorry about that. I see Allison, you're here, and Tamika, you're also here, so that's great. So as I said, we'll just give it one more minute and then we'll get going. So welcome everyone. This is the meeting of the Joint Advisory Council. I see that there are many of the members of the council who are enrolled as panelists in this WebEx meeting, and then I see that there are currently about 90 attendees, so welcome everyone. My name is Roger Bearden. For those who don't know me, I'm the Executive Deputy Commissioner at OPWTD. So we are going to get going. And maybe just turn the next slide. Do we have an agenda slide or no, Josie? Thank you so much. So that is the welcome and update. Obviously, in the last 6 months or so, a little more at this point, we've all been dealing with the global public health emergency, and that has been a primary focus in all of our lives. We, I think, missed our last quarterly meeting as a result of that, but we wanted to try to get back on schedule and working together on the Joint Advisory Council items. So first, just a look at the agenda. We're going to give an update on the SIP PL public comment. We were submitted for further public comment, I believe, back in February. Extended the deadline for comment a couple of times in light of the COVID-19 public health emergency, and then concluded that in mid to late June. So Allison McCarthy will be kind of taking us through a high-level overview of that. The second item is the Clinical Advisory Group has continued to meet and review potential value-based payment strategies, and that would be something that Tamika Black will address. And then the third item is we have received some consulting assistance from what's called the Medicaid Innovation Accelerator Program, which is a federal opportunity that we were able to avail ourselves of over the last number of months. And that is something also Tamika Black has spearheaded. Certainly, as we move through the agenda, would welcome questions, comments from the members of the Advisory Council, hoping that folks have a facility potentially with the chat feature, which you can send a chat to either Josie, who is the meeting host, or to the panel. You can also raise your hand. Josie will see that and be able to cue you in. We'd like to make this a dialogue, not a monologue. And for members of the public who may be participating via remote WebEx, if you include comments in the chat function, we can kind of scrape those, take a look at them, and try our best to have those comments be addressed. And if those comments are not able to be addressed, we can we would try to address them subsequently. Thanks very much, and let me move over to Allison McCarthy, please.
Good morning. Can you hear me, Roger?
Yes, we can.
Very good. Good morning, everyone. It's nice to be back engaged with you all. It's been quite last few months of a lot of hard work and attention to the current emergency, and it's nice to see your faces as much as we can. Apologies for not having a camera. We're working on that technology, and next time I will certainly be able to be seen. Today, we just wanted to take a few minutes to touch on the SIP-PL public comment. You can go to the next slide, Josie. As Roger had mentioned, we had released a draft back in August of 2018, and then we had issued another draft this past February. As Roger also mentioned, we did extend that due date for public comment a few times given the COVID emergency. So public comment did close out on June 25th. Next slide, Josie. And we received many comments. I believe comments and questions came from 125 stakeholders. These included comments or questions from individuals and families, advocacy groups, providers, our CCOs, and existing managed care organizations, which included the emerging SIP-PLs. Next slide, Josie. So I just wanted to take a couple minutes to review some of the trends or themes that we heard from stakeholders. We heard from individuals and families on a consistent basis that they really just want to understand how managed care will affect their current experience. So, what will it mean for me? So that's the common theme we heard. In addition, we heard interest in understanding how rate development works. Today, we have a cost-based rate methodology. And as you transition to managed care, you move to a per member per month capitation payment. And stakeholders expressed an interest in understanding how that works. I think as many of you know, after we've spent some time with this council, rates for managed care need to be actuarially sound, which means you have independent actuaries. Right now, the state's actuary firm is Deloitte, who work to ensure that, as you put a rate out into the market, it is an actuarially sound rate. So I think stakeholders are interested in just understanding how that works a little bit more, and also requested that a data book be released for review and use by emerging plans. Next slide, Josie. So we also heard a lot about, current crisis. Obviously, we've experienced a workforce challenge. It's likely even worse with COVID-19, and there wants to be an understanding that the implementation of managed care won't impede or make that workforce crisis any worse. We heard from many self-direction stakeholders that their interest in maintaining that full budget authority as you transition to managed care. And we also heard consistent input on the need for an independent ombudsman. So those are kind of three areas that we heard from several stakeholders around, and that ombudsman program and the availability of that program on a regional basis was of great interest, and thought that should be in place. Next slide, Josie. Other themes that we heard from stakeholders around included VBP, value-based payment and quality. I think we've discussed that, there's not a tremendous amount of experience nationally in terms of developmental disability measures and measures that are specific to habilitation. So that was expressed on a consistent basis. And there was, a real desire and concern that measures need to align with the traditional goals of developmental disability services in New York State, and promote the outcomes that individuals are trying to achieve, which obviously, need to be individualized. So I think we'll hear more from Tamika as this meeting continues around VBP, and some important learning that we received nationally through our IAP experience and through recent guidance from Center for Medicaid and Medicare Services. So more to come on the VBP side. And then, the concept of medical necessity when it comes to habilitation, it's a area that we haven't spent time with, and it's difficult to apply a concept of medical necessity to habilitative supports and services. So that was a common theme we heard from stakeholders as well. Next slide, Josie. Two other areas that were expressed through public comment was the transparency of due process rights. So I think, that continues to be a priority for stakeholders, and as it should be. Due process rights are essential and need to be transparent. And then we also, received input that, managed care advisory group should be established, and it should include individuals and families to actively solicit feedback from stakeholders so that we ensure that any implementation or development work around implementation is being communicated transparently between, individuals who receive services and families who support their loved ones. So that was a common theme as well. Next slide, please. So what's next? I think it's kind of that million-dollar question, and what we can say is that we have the budget process commencing shortly, which will certainly make decisions around what's next for OPWD and the future of developmental disability services relative to managed care. We obviously need to consider both the long and short-term fiscal environment, and as I think you all know, it's a very challenging time. But we are very much encouraged by the continued communication from CMS and our national stakeholders around value-based payment strategies and the opportunities that exist both in fee-for-service and in managed care, and how an incremental approach to value-based payment strategies is essential. And it'll be nice to hear from Tamika, who's going to share some of that detail with you all to kind of get a sense of, how we can incrementally begin and continue to work towards a VBP strategy, regardless of our, short and long-term trajectory for managed care. So with that, I'm happy to take questions, and then, we'll be hearing from Tamika on the clinical advisory group work, as well as the IAP opportunity that Roger spoke of.
Thanks very much, Allison. So let me turn it and ask whether there are any of the members of the JAC that wanted to share a comment or have a question.
Hey, Roger, for some reason my interface changed. I have to get back to raising my hand, so I have to figure that out.
Okay, great. Thanks, Arnold.
No, just a really quick question is just in terms of trends. I think a significant topic that's still under discussion, at least among stakeholders, is whether managed care in its entirety is really a desirable model to transition to at this point. And I do know that for SANIS, we did make that general point that, our organization, based on the fact that we have not been reassured that the cost of operating managed care won't draw from services at this point, and the fact that it's not proven effective in terms of long-term supports and services, basically we say we don't support it moving forward until those things become known. And we believe there's others that feel this way, or actually I say we know that. So in terms of the comments that you got back, did you trend that and see how many of the 125 were pro-managed care and how many of those were opposed to managed care?
Sure. So we did take a look at those trends, and, it was consistent overall that individuals and families had more concerns, and self-advocates had more concerns about the potential for managed care implementation overall. I think, similar to your comment, there is a concern about, not only, what it means for me, but, how would we fund, an endeavor that, does cost money upon startup. So very much so. And then on the, organization, providers, emerging managed care plans, there's generally a more positive perspective in terms of potential implementation. Again, though, the same kind of need for transparency, understanding of, how capitation rate development works, assurance that services continue to be, or funds continue to be supporting services and don't go to administration. So I think, from a provider and CCO managed care organizational perspective, there was more, a positive trend, but similar to individuals and families, a need to understand and have transparency and really, plan over time that implementation strategy. So,
and if I could just,
I think,
Allison, if I could just throw in a note, it's a little hard to chart it because it wasn't a poll, right? Where there'd be a binary choice. There were a lot of the comments had. I would support if, I'm opposed, but could be supportive if, so there are a lot of things where people were sharing analysis or comment. So it's a little challenging to do straight up percentages, Arnold. Is that fair, Allison, as well? Just from my own reading of the comments.
Yep, absolutely.
All right, well, thank you.
We do have a comment in the chat speaking about a report from Deloitte as well as the data book, communicating that Deloitte did a presentation in Texas on a very similar IDD transition to managed care. I think that's absolutely something that can be looked at. I think, from a New York State Department of Health perspective, they do have Deloitte, who is the state's actuarial firm, share information to stakeholders, upon implementation of such a kind of initiative. So, thank you for pointing that out. It's, I think, a very good point.
And there's another comment in the chat room. There is not, at this point, a report on the comments other than the presentation that was just given. So it cannot be located because it does not at this point exist. And I saw also a comment asking for a posting of the link to the meeting materials, which we can certainly supply. Josie, I don't know if you're listening, where you can dump that in the chat box if you haven't already. Any other questions?
Yes.
Yep.
Can you hear me?
We can, Gail. Thank you.
Yes, I also had did the raised hand, but I don't think it was working. First of all, I thought that it was a very informative presentation. And I thought also that it was an excellent segue because one of the areas that was in the presentation was in regards to a managed care advisory group, which would include the participants, stakeholders, and their families, which is excellent. And I think having such a group would assist in whatever the concerns are in reference to managed care in general. So I think that is an excellent proposal or recommendation.
This is Susan Dua, and I'm wondering whether you have had a discussion and have material, a report on whether the model can be replicated.
I'm talking to you muted, Mike. I don't understand the question, to be quite honest, Susan, but maybe Allison, you do?
Actually, could you just, when you say model, can you just explain what what you mean by model, what you mean there.
I was talking about FIDA IDD and whether you have any discussion anywhere of whether it can be replicated, or will we be expecting that later in today's conversation?
Thank you for clarifying. That's very helpful. I think we definitely can take a look and do want to draw upon FIDA IDD. I think, you know, one of the differences is that's a model for dual individuals who have both Medicaid and Medicare. So that certainly is a model we can look at and work with Department of Health on as we move forward and think about that future. There's individuals who just have Medicaid, it would look a little bit different. And I think, you know, our goal is to look at that and outline that. I think recently we have not had a lot of time with Department of Health, who's been very busy, along with our team in addressing, you know, other priorities. But I think you make a very good point, and we absolutely want to continue to draw upon the FIDA experience as we move forward.
This is Elizabeth Benjamin. May I ask a question?
Sure.
Hi, thank you. Thank you for this really helpful presentation. And I apologize if you already explained this, but I'm just still playing catch up with all of this. Will the department will OPWDD have dual jurisdiction with SDOH on the plans, as it were, or will, like, now, yeah, can you kind of go through one? I'm sorry, there's a little bit of background. Can you talk about I mean, since it was just mentioned, the relationship with the Department of Health, how will that be navigated in a way that's like most successfully implemented for the folks that are the enrollees, I guess is where I'm trying to get at. Because I think it's difficult when you have sort of multiple jurisdiction. We see this a little bit in some of the other products out there. For example, you know, DFS and DOH, not that anybody's not all trying to work together, but it can be a little difficult, you know, for consumers. So for example, the Department of Financial Services consumer report doesn't include data, and I've addressed this directly, so I'm not telling any, you know, no dirty laundry here. It's not a complaint, but just because of the way PHPs grew up different than health plans grew up, the consumer data and quality and complaint and appeals and external review data that's put in the Department of Financial Services report doesn't include, you know, health plans that serve half the individual market. You know, so for example, Fidelis, Health First, Metro Plus, none of those plans information are included in the very consumer guide that's supposed to help people sort of understand what health plan might be most effective for them and to have a better sense of things. So I think that's been sort of a bit of a hiccup as managed care has evolved over the last couple of decades in New York State. And I'm just wondering how OPWDD is thinking about navigating those, you know, sometimes choppy waters, but not always.
Sure. Roger, I don't know if you are on mute, but I'm happy to.
Yeah, I can. Yeah, sorry. I'm trying to avoid the background noise. Yeah, no, I can give. I think the intention would be that there would be a joint authority between the two agencies, the Department of Health and OPWDD, and an oversight of plans serving individuals with developmental disabilities. And if I'm not mistaken, I think that the authorizing legislation, in fact, explicitly contemplates that. And in terms of the specifics of that, and your point is well taken, Elizabeth, regarding DFS, you know, that would probably need to be worked out through, you know, through MOUs, just to make sure, you know, we knew who was doing what, and we haven't gotten there yet. I don't know, Allison, is that fair?
Yep, that's fair.
I think there's like certain obvious things that can be kind of tricky, you know, networks, who's doing the network analysis, just, what consumer protections guide these products, it's just, there's a lot of kind of, we don't have to I don't need to make a big thing of it now. I just would love to, we've been we've been sort of thinking this through the consumer perspective for a couple of decades here. And so like we have, if it would be helpful, we can talk about this some more, either in this context or at a later meeting when we're further along, or I would just love if maybe at the next meeting we could talk about those streams of authority, who's doing what, just so that people really, that as the population moves in, that they really have an understanding of, okay, if I have a network complaint, where do I go? If I need to do an appeal, who's in charge of that? Which agency am I supposed to be complaining to? Because what we don't want is, depending on which kind of what kind of complaint you have, you could either go to DOH or OPWDD or DFS, or like that can be a little chaotic for people to understand and navigate. Just by way of an example.
I think it's well taken, Elizabeth, and to the degree to which certainly your experience in navigating in other sectors, and you were to have some thoughts about common mistakes that have been made in the past, that could be remedied and addressed on the front end. That would be, I think, more than helpful. So we would look forward to any kind of information, any kind of lessons learned that you might be able to offer from the consumer perspective. Sankar, it looks like you have your hand up.
Yes, sir.
I'm sorry, before Sankar, I'm sorry, I skipped over. Maxine George had her hand up. I'm sorry, Sankar. Let's go with Maxine first and then Sankar.
Okay.
Hi, thank you, Walter, for allowing me to speak here. There's so many things up in the air here around how we're going to pull through with this managed care, and it all seems so confusing and chaotic. But in one of your earlier slides, you mentioned actuarially sound rates to maintain services. How can we be talking about transitioning to such a complex system as managed care if we have no idea whether or not the rates that are going to be rolled out will sustain some of the core programs or services that our families have come to treasure?
I'm going to have to defer. I am not a rate setter, so I don't know, Allison. I know you're not either. Should we take that question back?
Sure. I mean, I think, to your point, Maxine, it's absolutely critical that we take a step back and consider where we sit today and, what the environment, and what providers are experiencing today with challenges on the table. And as I mentioned, we will be taking time to assess what our next steps are and, what the trajectory looks like, and it needs to take into consideration your point. So thank you for bringing that up.
So now Sankar.
Thank you for the opportunity. It's always great to have these sessions where you can share information with the field. My interest is in, as a provider that's been interested in managed care for a long time and operates a managed long-term care plan in upstate New York, an IDD provider. I was following the presentation, and you had talked about the concerns that as part of the comment period, the concerns you had from the individuals, families, those in self-determination. And then we talked about next steps, and you are on this slide right now. And maybe I'm jumping ahead, but I was interested to know if you're having, OPWDD is having any conversations with any of these individual provider organizations or groups that are thinking about managed care and maybe operating a managed care plan on behalf of people with IDD. Can you share any information that you might have?
So Sankar, I'm trying to understand the question. Are we having discussions with?
Right.
I'm sorry. I'm just.
Yes.
So I think we have almost daily discussions with some set of stakeholders. I mean, obviously, in the last number of months, those discussions have focused, I think, quite appropriately on the public health emergency and, you know, obviously keeping people safe and healthy. Yeah, I mean, are there conversations or discussions you would suggest we should be having? I guess I mean, this is a conversation and a discussion as well. Yeah.
Right. I would just urge that maybe we could include those, you know, the organizations and see where they are and what information they might provide, because obviously there's a lot of concern and yet there's a lot of interest as well. So, I mean, that would be my feedback, that we have some conversation with providers that are thinking about moving to managed care as well.
Okay.
All right. Thanks.
Thanks. I'm looking, trying to navigate the Arnold. Do you have a question in the chat room? I don't know if you wanted to articulate that, or if you want to allow that to stand kind of alone as a question.
I can paraphrase it. I suppose it's a little lengthy. Just as far as you know, how have you examined how to continue conflict-free case management? Because my understanding is, you know, CCOs in some cases may be able to become SIP-PLs, so which means effectively they'll be allocating funding to services, which seem to be a significant conflict of interest. You know, and also, I guess further say that, you know, I guess defining the business relationships that they also might form with emerging MCOs would probably be important to look at as well in terms of conflict. So, yeah, so what's been looked at, you know, there?
Allison, I don't know if you want to address that. I believe that there has been some analysis on that topic.
I mean, I think it's a good point in terms of needing to be clarified in, you know, as we engage with Department of Health and look to the future, you know, we'll be drilling down a bit more in terms of that specific relationship. I think, you know, there are firewalls when you institute an Article 44 plan that requires, you know, arm's length and conflict free. So, you know, those firewalls and protections will absolutely be reviewed and identified and established. So, you know, it's, you know, I think as we move forward, we'll need to be focused on that area specifically.
Okay, and I see some other comments which are comments. I'm just trying to look at those in response to one question from a member of the public. No, so the SIP-PLs have not been established at this point. There was comment received on the proposed model, and that was what was reviewed in the presentation that just occurred. But those entities have not been formally established to provide managed care for developmental disability services. And I think people are aware of this, but just in the event that it's more fully responsive, there is a current program called the FIDA program for people who are dual eligible, meaning they have Medicare and Medicaid, and those individuals in a downstate region can enroll in that program, and that's been a program that's been operating for several years now. So I'm going to perhaps move on to the second item on the agenda without the IDEA Clinical Advisory Group. And then what we'll do is take a look at the chat room, and I'll try to scrape any of the comments that have been made and circle them around to sort of a Q&A section afterwards. So please feel free to keep putting in comments. They'll be reviewed, and we'll see if we can digest them into single set of answers as we go through. So with that, I'm going to pivot over to Tamika. Hi, Tamika.
Hi, Roger. Can you hear me?
We can. Thank you so much. Hi, Tamika. And let me pivot over to talk about the CAG.
Good morning, everyone. I am giving an update on the Clinical Advisory Group. Josie, can you please move to the next slide? So I know it's been some time since the JAC has met. Since then, the CAG met on July 9th, 2020. And our key focus for the CAG meeting was really around clinical quality measurement for IDD, quality measure use cases, and the measure evaluation framework that the CAG would use in terms of measure selection. We also discussed the next steps for the CAG, and I think this dovetails nicely into the point made earlier about there being valid and nationally recognized measures relative to IDD, and I think this is a great opportunity to discuss some of the work that has been underway. Next slide, please. When the Department of Health presented some of the information in the last CAG meeting in July, one of their focuses was really talking about clinical quality measurement goals for IDD. And for those of you who are not aware, the CAG is co-chaired by Douglas Fish, who's an MD at the Department of Health, and Jill Pettinger, Dr. Jill Pettinger here at OPWDD. And what we try to do is bring together both the DOH perspective as well as the OPWD perspective in terms of thinking about quality measurement and thinking about ways to leverage DOH's experience around quality measurement. So one of the things that became a key focus, especially as a result of the COVID-19 public health emergency, was the need to really look at quality measurement relative to IDD. One of the first focus areas was really thinking through whole person measurement. And that's really where measures of all services that support the overall health and well-being of a person are taken into account. And they should include and ensure that individuals receive quality of care and prevent institutionalization. One of the other key focuses, both of DOH and OPWDD, is making sure that when we think about clinical quality measurement, we're looking at disparities in care. And the goal is to use standard measures across populations, as well as to identify gaps in care so that we can address those through quality improvement mechanisms. One of the final areas that we think we'll be able to really leverage is building on the use of clinical quality measurement in managed care. Irrespective of what the ultimate service delivery model is, there's tremendous experience that the Department of Health has regarding quality measures. And so New York State assesses health plans on these quality measures, and they're useful for comparing health plan performance. But they also give us a real historical perspective of the use of measures over time, the validity of those measures, and the reliability of those measures. Next slide, please. When we also think about using measures, we also want to look in the frameworks in which they've been applied. And there are four major frameworks where measures have been used so far. Clearly, one of the more robust areas for the Department of Health really is managed care. And in that regard, the state assesses plan performance on care processes, outcomes, or the patient care experience. And at that point, CMS is also responsible for overseeing the state's managed care programs. There's also experience with VBP in managed care and using measures in that framework. And that's where plans pay their contracted providers based on performance and specific quality measures. And that's essentially incentivizing quality of care, and there are a variety of payment mechanisms to do so. In this arrangement, CMS is also responsible for overseeing states' VBP managed care programs. We also have our current system, which consists of waiver programs, and that's our fee-for-service area. And CMS and states assess waiver program performance or evaluate enrollees' experience in receiving home and community-based services. Measures may be included in states' waiver agreements with CMS. And finally, we've been looking at a newer area as CMS has been assisting states with technical assistance, of which New York State has been part of that process in the IAP, or the Innovation Accelerator program, of really looking at ways in which states have been able to use VBP for waiver service, and that's value-based payment. In that arrangement, waiver programs pay contracted HCBS providers based on performance on specific quality measures, and the measures used in VBP may be included in the state's waiver agreements with CMS. So these are 4 different frameworks, and what it does illustrate is that VBP approaches can be used in a variety of ways and a variety of structures. And so when we think about VBP, we're looking at the quality measurement in of itself and not necessarily the service delivery system in which it's embedded. Next slide, please. So one of the things that we have been exploring with the IDD CAG is really quality measures and use cases. So essentially, quality measures are tools that help measure or quantify care processes, outcomes, patient perceptions, organizational structure, or systems. And it's essentially saying how good a job are we doing at delivering services or care, and are individuals achieving the health outcomes or the habilitative outcomes that they desire. Measures are developed for distinct purposes, and those are what we call use cases. And that's essentially to assess performance of specific entities. And there's a particular level of analysis or unit of analysis. It can be at the health plan level, the provider level, or it can be at the whole healthcare system level. The originally intended use cases are important to consider when evaluating quality measures. So for example, you wouldn't want to apply a healthcare delivery system measure to individual care. You want to keep it at the right unit of analysis. So there are a lot of things to consider when we think about quality measures, how they're used, and what perspective or entity they apply to. Next slide, please. So hopefully you can see this one clearly. Here's an example of use cases by measure set, and we really wanted to begin to ground this in the IDD system. One of the major use cases is, do we have any kind of experience with measures for HCBS or the IDD system? And here we list a few of those. We have the National Core Indicators. We have Care Coordination Organization health home measures. We have personal outcome measures. We have home and community-based services, or CAPS measures, and 1915C HCBS waiver performance measures. So there is experience with measures around IDD. I do want to add something about the National Core Indicators, which really is a new development, which I think is very helpful to moving us forward when we think about a reliable and valid measure set. New York State has been reporting measures on the Department of Health side in the adult core measure set. The core set, they've been reporting for over 10 years. And the measures are compiled from a variety of sources, including data from plans via QAR, or the Quality Assurance Reporting Requirements data set, from the AIDS Institute, as well as DISRIP data. So there's experience with this core measure set. National Core Indicators, as of 2020, has been included in this core measure set that with CMS, which has been great news for us. New York State, on the IDD front, has been participating in National Core Indicators for over 10 years also. So having the IDD measures around National Core Indicators included in the adult core measure set is a move towards that reliability and valid measure set that we've been looking for. When we think about National Core Indicators, and for those of you who had a chance to either look at the public-facing website or the New York profiles for National Core Indicators, they get at those measures, which I think are very important to the IDD population, anywhere from, do you have a job in the community? Do you have a choice of roommate? What are the quality of your services? They've also added measures around care management. So there's a lot of opportunity around NCI for further development. We've also been engaged with HSRI, who helps administer the national core indicators, in developing new measures. So if there are areas that we want to collect data on, we have the ability as a state to provide that input, and OPWDD has been engaged in that process. So as we move forward from the HCBS or the IDD system measures, and I just want to make sure that I just illuminate where some of these measures are. For the Care Coordination Organization measures, those are in the CCO application, which I believe are available through the DOH website. The CQL POMs, the Council of Quality Leadership, personal outcome measures, I think, have been sort of embedded in the IDD system for New York State, and I think everyone's pretty familiar with those, as similar to the CAPS measures, which are a very common measure set that's used. And for those of you who don't know, we're required to report annually to CMS on HCBS waiver performance measures. The next use case is around long-term services and support, long-term care services and supports, and we have some experience in that around the NCQA, LTSS data set, the New York Managed Long-Term Care measures, the MLTC, potentially avoidable hospitalization measures, and those we've been working with the Department of Health to really underscore their experience with those measure sets, and can they be applied to the IDD population. And similarly, clinical measures, and again, there's familiarity with those where we're looking at HEDIS, or the Healthcare Effectiveness Data and Information Set, as well as CAPS, again, for the Consumer Assessment of Healthcare Providers and Systems program. So we have a variety of opportunities to look at these measures, which are considered to be, I think, some of the more, again, reliable and valid measure sets for opportunities to look at opportunities to advance IDD system measures. Next slide, please. So as we proceed with the CAG, and for many of you who may already know, the IDD CAG, as well as all the other clinical advisory groups, are outlined in the New York State Department of Health Value-Based Payments Roadmap. We work in collaboration with the Department of Health to administer and direct and facilitate the CAG. And as part of that, we're also using New York State's DOH's evaluation criteria for measures. And there are 4 key things that we're looking for when the CAGs are reviewing and selecting measures. One is the relevance, the second is the validity of the measure, the third is the reliability, and the fourth is the feasibility of the measure. So in terms of relevance, and I think, again, this harkens back to what was said earlier, we're really looking for measures that are useful for quality reporting and decision making. We're also looking at the level in which the measure has been applied. Has it been plan specific? Has it been applied to a provider? Are the data collected at the individual level or the health record level? How are we getting the information, and who does it apply to? The other thing we're also looking for is, does the measure make sense when applied to IDD? And again, these are the things that are considered when is the measure actually relevant? For validity, we want to make sure that the measure and data is correct and it's free from error, so that it's not, and both in validity and reliability, that it's measuring what it's intended to. We want to make sure that they're well defined, that there's no confusion around the specification of the measure, and that we can collect data accurately and really reflect quality. And also, too, that we can actually make distinctions in performance. For example, when results of a measure cluster closely together, so everyone gets a 99.9, 0.8, 0.7, that's not really telling us maybe in a measure that where someone's at 70%, and I'm using this in arbitrary, but someone's at 90%. When we want to think about measures, we want to be able to distinguish performance level, and we don't want people clustering around a particular performance standard. For reliability, we want to make sure that, again, it's well defined to allow consistent implementation. If everyone interprets the measure differently, you'll collect different types of data, and there won't be reliability in the data that's reported. We also want to make sure that it's specified from data elements and it's repeatable, so that anybody having the same information and the same specifications could repeat the data collection and the calculation of any measures. There's also needed testing of all intended levels of analysis to make sure, again, that they are reliable. And finally, one of the most important is that it's actually feasible, that the data is actually there, it can be collected, it can be aggregated, and without an undue burden. We want to make sure that, you know, we can actually collect information, report on it in a way that's feasible, and again, does not require a huge resource strain on the field, on providers to be able to report. Next slide, please. One of the things we're also looking at is how the CAG will work in terms of leveraging measure specifications. So we're looking at how that measure is defined, the numerator and the denominator, what it really means, what data is collected, where is that information coming from. And if that specification is clear, we move forward into looking at the 4 conditions that are you know, the next steps for us in evaluating measures and looking at those very carefully, which again is the work that the CAG will be doing as we move forward. Next slide, please. So in terms of next steps for the CAG and the recommendations that we have, again, from July meeting, we're really going to be focusing on evaluating and recommending specific HCBS and or long-term sports and service measures, sets, and measures. The IDD CAG will assist OPWDD and Department of Health with providing an IDD perspective on clinical quality measures, and CAG members can help identify implementation and reporting challenges, which I think are very important, that may be faced when implementing clinical quality measures for IDD. Next slide, please. So I think that's the end of that portion of the presentation. I don't know if we want to stop for questions at this point, Roger, or wait until the end.
Just getting myself off mute. Tamika, I don't know if you can see in the chat room, there was a series of questions. I'll let you kind of browse those for a minute, maybe scroll up while I'm asking the question as to whether panel members, the members of the JAC, have any questions, comments at this point on the CAG readout that Tamika was able to provide. Josie, are there any hands up that I'm not seeing?
I show no new hands.
Gotcha.
There are quite
Tamika, if you can maybe summarize those comments, because I'm not sure that everybody can see that, and
okay.
any readout or views you may have. Thanks.
So I will try to generalize comments. We have quite a few comments here, so it's great to see that everybody is engaged in the conversation when we think about measures, and that's a wonderful thing. I'm always interested in debate and deliberation and really thinking through a mindful and thoughtful approach as we move forward. So I think we've gotten quite a few comments from Ralph Warren, who's one of the panelists, and I think here we're seeing that there's an ongoing problem going back more than 1 year on the IDD CAG use of the POMs, and the CAG, I think he's saying inconsistent and illogical in the use of measurement standards among the POMs. In other words, some POM items were picked and others were omitted without regard to strict measurement standards DOH uses in other CAGs. I think again, this CAG has been reconvened from the original CAG. Now, the original CAG that occurred, I believe it was in 2016, did identify initial measures, and some of them were clinical measures, and some of them were, I believe, related to the POMs. We have started from a different collaborative framework for the second round of the IDD CAG, and are really trying to look at more thoughtfully around the selection of measures. And we're using a great amount of assistance from Department of Health in thinking through the applicability and consistency across the CAGs. So we're using the complete DOH framework, which includes the VBP steering committee review. Doug Fish operates and oversees all of the clinical advisory groups. So his work in bringing in the IDD CAG along with the other CAGs, is creating that level of consistency and that framework. So we're working together and we're developing the expertise as we go and are leveraging the existing expertise of the Department of Health. And I think there was interest in actually knowing what specific measures we are recommending. The CAG is going to be embarking on that process. So we are not recommending any measures at this point. We're telling you the framework we're using to begin measure selection, the importance of the selection criteria, and the work that we're doing to ensure that we're selecting measures appropriately.
Thanks, Tamika. And I believe that those meetings, similar to this one, are held publicly, and so folks have the opportunity to participate as we look into the fall and the winter in those discussions. And am I correct in that?
The clinical advisory group is not a public meeting. However, the information and the PowerPoints are posted on the DOH website. So if anyone is interested in looking at the work the CAG has done so far, this information can be found on the Department of Health website.
And I'm glad you mentioned that, because there was a request for the link for that information, so we can find that and throw that into the chat room.
And I'll double check, Roger, to make sure that the information from the July CAG has been posted. I know with everything going on related to the public health emergency, I just want to make sure that we have that up to date so that anyone who's interested can also review those slides.
That's terrific. Thank you, Tamika. Donna Colonna, I believe, has her hand up. Donna?
Can you hear
Donna,
me?
if you're speaking, we can hear you now. Thank you, Donna.
Okay, yeah. Oh, thank you, Tamika. Thanks, Roger. I actually participated in the recent CAG, and I think there was some really good conversations in terms of looking at different measures and improving care. And the one thing that always strikes me, though, is that for integration with flexibility and integration with health care. And flexibility in terms of some of the I call it the platform for that. So I know that we're actually talking about, kind of crafting the future, so to speak. So I think it's really important that whatever platform we create, we need to be able to bring in health. I think our experience in COVID and sort of trying to push and work with the healthcare side of what the healthcare side, probably whether it's hospitals, family practice, that are challenging access and some of those standards, for example, whether it's heated or some of the other standards the Department of Health is looking at, without a real integrated approach and a flexible approach, it's really to a whole person approach for the people that we serve. So I just would love for us to have, about like what would that, how do we get there? Because I think that's how we started the Joint Advisory Group. I couldn't believe it was like 2013, I think was when we started. So I think it was discussed really important, but we have to get to a whole person approach, at least in my view.
Thanks, Donna. And I'm seeing that in the chat room, one of the commenters put in the web address for the, I can seems to indicate that some of the materials may not have been updated. So if that's the case, we can certainly work with the Department of Health to make sure that that is has current and accurate information. Maxine, I don't know if you are trying to get a word in or not. Your hand is still up, but it might be from the previous time.
Sorry.
It's fine.
It's down. I'm sorry. Oops. It says
No,
it's down, but
no worries. Thanks.
Okay.
Thanks, Maxine. And then it looks like Steve Klein. Oh, sorry, that's a non-panelist. Just that's another question. I'm just looking. Tamika, do you see any more questions in there that you don't think have been addressed yet?
I think there have been questions again about the reliability and validity of the measure set and how we're approaching that. Again, I think that is the continued work of the clinical advisory group. And I think after our next set of CAG meetings, we'll have a great opportunity to update the JAC on the direction that we are taking. When we also think about reliability and validity, we're also working with the Department of Health Office of Quality and Patient Safety, OQPS, which has a substantial, I would say, research and data infrastructure underneath it. And we are using, again, their calculation of measures and their approaches in a way and making sure that we are making sure that it fits the IDD system. It's not simply just taking a measure and copying it over to the IDD space, but we're looking at it very thoughtfully from a variety of perspectives, clinically, methodologically, as well as programmatically. So there is much more work to be done. And I think what I also want to say is that this is a foundation. I think there is a perception of if we can, the perfection is not going to be achieved in the first round. We will not isolate every perfect measure, but what we will do is start on a process of refining, of getting data, of using data and getting better at it over time. And as a result of that, getting more reliable and valid information. I think everybody wants to start off with this sort of holy grail. The IDD arena is very new. I mean, we're at the forefront of this conversation, and to simply find, I would say, concerns about measures are absolutely true. You do not want to go out with anything that is arbitrary or does not measure what's intended. At the same time, we have to begin the process somewhere, and there needs to be that conversation about how do we begin to build capacity. How do we understand data literacy, and how do we move forward with using measures, refining them, building on experience, and being a leader in that regard? So because it hasn't done before does not mean it's impossible. What it means is that we have to be thoughtful and really mindful of our approach, but we also have to be willing to have some opportunities to be successful in areas and also work in some areas to do better. So I did want to put that out there. We have some questions around social determinants of health, which is also another key area that we're looking at through the CAG. And I'm sorry if it didn't seem like I touched on that. That does factor in. We're continuing to sort of develop, again, that approach and that framework with the Department of Health. So I think I've done largely some justice to the comments. There's much more here, and hopefully, Josie, you're tracking the questions and comments for me so I can look back at these.
Yeah, we can scrape the comments at the end of the session and throw them into a file so that we make sure that those are preserved. Maybe that we can just pivot to the next item on the agenda, which is a readout. And I don't believe we previously discussed this program because it was an opportunity that came about rather quickly and a short turnaround for the consultants who were able to provide some assistance to us. And obviously, this is highly related to achieving valued outcomes through our payment methodologies. So with that, let me pivot once again back to Tamika to take us through some information on the Medicaid Innovation Accelerator Program. Thank you very much, Tamika.
Thank you, Roger. So this is another initiative that we've been participating in, and thank you, Josie. We were awarded an opportunity to receive technical assistance from CMS as part of the Innovation Accelerator Program, and select states are offered this opportunity to join their various team of consultants to sort of work through approaches towards value-based payments. The IAP team that we participated in ran from February to August 2020, and it included Department of Health and OPWDD. Next slide, please. One of the things I did want to mention is that while we were very excited about our IAP opportunity and we had a very ambitious agenda, we encountered some key challenges during the progress. Clearly, we had the COVID-19 public health emergency, which changed the nature of the focus as well as our ability to participate at the level that is usually needed through the IAP. And it's consistent either weekly and biweekly meetings and a tremendous amount of work and effort. The original team was moving towards fiscal modeling and financial simulations and developing complex approaches to thinking about VBP. That didn't happen in the same way that we initially intended. Our technical assistance ended in August 31st, so we had a very limited time frame between February and August, and there wasn't an ability to extend the IEP. And so as a result of that, it changed the trajectory from the initial aim of having this deliverable-based focus on analysis to more about consulting and learning as we worked with our partners at CMS. The team that we participated with included NORC at the University of Chicago, RAND, ARC, which was an actuarial company, Stratus Health, and others. What it did lend itself to was a large-scale sort of opportunity for OPWDD, which was phenomenal. We had the ability to access expertise and resources. We really had an opportunity to assess our current state and think about leveraging capacity of our existing system towards VBP. We could support the continued focus on data. We could gain a further understanding of VBP arrangements and alternative payment models. We had the opportunity to identify foundational steps and considerations for the IDD system, irrespective of funding or service delivery models. We learned from other state experience, and we had an opportunity to review our OPWDD stakeholder engagement process. So even despite having a limited resource available to us at this point relative to the state capacity to participate, we came away with a lot from the experience. Next slide, please. So in terms of current state initiatives, again, many of you are familiar with this. We've talked about these. We have the VBP roadmap, which is available on the Department of Health website. It was part of the 1115 Delivery System Reform Initiative, DSRIP. And the goal, when the VBP roadmap was first drafted, was a payment reform goal to reach 80% value-based payment arrangements. Provider stakeholder standards and guidance for creating VBP arrangements were really specified in that document. We also have the IDD Clinical Advisory Group, which is part of that VBP roadmap, and we talked about the update just a few minutes ago. We began the process in 2019, and we've been using clinical expertise and industry knowledge to try to move forward in looking at measure sets for IDD services in the population. The goal of the CAG is also to make recommendations and provide feedback on quality measure sets. We also have the experience of the FIDA IDD demonstration, which has been very important to us. This is a 5-year demo for the fully integrated dual advantage plan program. And it's an ongoing partnership between OPWDD, DOH, CMS, and Partners Health Plan. Someone had mentioned earlier about replicating the model. We would refer to it more as leveraging the model, learning, from that experience. They're not exactly the same. And as Allison had pointed out, this is for dually eligible individuals. However, there are things that we can learn about the measurement process, about the measures that the FIDA has to report, that data collection, and the reliability and validity of those measures. And so PHP is also part of the IDD CAG, and they have shared their insights around data collection, around measures, and that was on one of the earlier CAGs, and I believe that PowerPoint is on the DOH website. In addition, we also have IDD Health Homes, which again has been a key part of our service system effective July 1st, 2018. And again, the goal of the CCO is to deliver person-centered planning and care management services and cover, over 100,000 individuals with IDD. Next slide, please. So the opportunities for aligning the IAP with state initiatives and goals. again, we want to be able to use these pieces that we have available to us and think about how do we move forward. Someone commented about the JAC, I think, forming in 2013. Again, change and developing a service delivery system or transitioning to managed care is a long road. And one of the things we wanted to do with the IEP experience was figure out how we can leverage, how do we get there? So one of the things we discussed in the IEP around the IDD health homes was thinking about ways to enhance capacity to measure quality outcomes and support VBP models through a more integrated and person-centered care management process. Another way we were looking at is how to think about the quality measures that we're recommending through the IDD CAG to support VBP, including for HCBS. How to leverage managed care and build on the experience that we already have, both in the FIDA IDD as well as mainstream, and think about ways that helps us leverage opportunities for VBP design in HCBS. Looking at waiver redesign, and as we think forward after the public health emergency, looking at flexibility, looking at equity, sustainability, those key principles, and looking at the waiver design process and how we can create and look at measures through the waiver, and how do we support education, lifelong learning, and helping adults engage in citizenship. We also want to look at incentives and measures in that space. And again, we want to also update the VBP roadmap to reflect any new directions, and DOH is fully informed about that and wants us to update the roadmap as we continue to refine the direction that OPWDD is headed. Next slide, please. One of the things that became very important to us in understanding the move to VBP is the importance of data. And so I just want to reiterate OPWDD's data strategy initiative, because at the foundation of any sort of quality measurement system is actually having access to the information, having systems, IT systems, having the ability to analyze, collect, report effectively, both on the provider side, but also for OPWDD. One of our goals in OPWDD is really to promote accountability and transparency for individuals, families, providers, employees, and our stakeholders. And it has been an aim that we have been focusing on for the past year and a half. We want to be able to provide accurate, timely, and actionable data to support decision-making, as well as look at the IT systems and the data as the source. We also want to balance quality and performance reporting with assurances that person-specific confidential data will be handled appropriately. Privacy and security are one of the key focus areas as we seek to be more data-driven. Next slide, please. In terms of our data strategy, and we've talked about this in the JAC before, but it's coming together under the context of the VBP, is that we've developed a high-level roadmap for milestones for achieving our data strategy. We've instituted data governance to ensure that we have accurate and reliable sources for our data and that we're safeguarding that data. We're looking at data sharing and looking at DUAs and how we can actually share data, and also looking at open data, which is one of our key initiatives to expand on, and then also developing our quality strategy. And the clinical advisory group is part of that quality strategy, as well as exploring development of new quality measures and monitoring service delivery and provider performance. Next slide, please. In terms of the VBP roadmap, it's a highly technical document, but this distills down the 6 major pieces of that roadmap. The first thing is the outcomes that we expect to achieve. Who actually is the target population? What are the quality measures that we intend to use? What is the data and the information systems that support the VBP model? What are the services to support our strategy, with waiver and non-waiver services included in the model? And the payment method used to incentivize quality and effectiveness. One of the other things that we need to really talk about is the target population is also attribution. Who's ultimately responsible for delivering those services, and who would be the beneficiaries of any VBP strategy or incentives. Next slide, please. One of the 3 key areas we discussed with the the CMS IEP team are the key goals for that are proposed for our VBP models. The first one is how to best support people to live in the most integrated setting. How do we incentivize employment first? And how do we continue to incentivize comprehensive care coordination? So we went into the IEP experience with those three major system goals. Next slide, please. As part of the IEP work, we went through the alternative payment framework, and we'll talk a little bit more about that framework in future slides. Our IEP focus really was, and this was counter to what we initially expected, was meeting states where they are. Many of the states, based on our work with the IEP, were very aspirational in where the directions that they were headed. The IEP actually, again, allows you to leverage and look at where the system currently is and what are the opportunities in the current space as well as in the future space. Identifying building blocks, leveraging a continuum of progressive steps, and promoting value and quality through existing system capacity. And I think that was a great framework for OPWDD as we, again, are starting this sort of foundational walk towards more complex payment arrangements. Next slide, please. So here is the alternative payment framework. It starts off with fee-for-service arrangements with no link to quality and value, and often this is where many states have started. And then they move on to Category 2, which was one of the space where we spent a lot of our time in the VBP IEP talking about. And that was linking fee-for-service to quality and value and using foundational payments for infrastructure and operations, pay for reporting, and pay for performance arrangements. And how could those be operationalized potentially for New York State? We also talked about Category 3 and Category 4 to also provide some examples of how we might transition from the Category 2 to ultimately 3 and 4 payment arrangements. And again, those are the ones that are more traditionally familiar with for VBP, most often specifically Category 3, B, and 4, A, B, and C, moving forward and oftentimes managed care arrangements. So we went through the gamut of this and really talked about where New York State is now and where we ultimately want to be. Next slide, please. As a result of that conversation, the consulting team was able to identify a few states who are walking or have walked a similar trajectory as to New York State. What they did is actually identify where we have a baseline system of health homes and how they've been able to use this, the health home framework to begin to develop VBP arrangements. So in the District of Columbia, they have 2 health home programs, and they were able to use Category 2A foundational payments. They were also able to incentivize health homes to make greater use of data. So the state created a VBP structure to actually support the transformation of the process to being more data-driven. And they used a pay-for-performance model, and they were reimbursed for meeting quality metrics. And that was actually an example of a Category 2C pay-for-performance payment. Next slide, please. We also learned about South Dakota that was also able to use its health home model to target both individuals with chronic medical conditions as well as those with serious mental illness. We talked a lot about being able to further cross-system collaboration and integration for OPWDD in our health system. And so there was an opportunity there to look at foundational 2A payments and Category 2A payments, also to continue to support health homes with smaller caseloads. They were also able to look at quality measures in the context of pay-for-performance arrangements and using statewide averages, using quartiles to be able to assess performance, and again, using 2C pay-for-performance payments. Next slide, please. We also had the opportunity to explore California's experience And the IEP thought there was a interesting amount of opportunity here to think about this context also for New York State, not necessarily in terms of housing navigation, but the opportunity to build into the care management process key areas where the state would like to see some of its VBP goals being met. In the case of California, they focused on a housing navigator program, and were able to use VBP arrangements to allow individuals who may be at risk for homelessness to be able to find housing and partner and create a supportive network to be able to find housing. And their structure also was using foundational payments with options for pay for performance and reporting. Next slide, please. And then finally, we looked at Tennessee and the specificity of their arrangements, where they were in a more complex 3A shared savings arrangement. So they've moved on in their trajectory, and their health homes are overseen by their MCOs, which also set the health home rate. We looked at theirs, the use of the state's use of HEDIS, and so they elected to use HEDIS because it could be calculated using claims data. And again, this is VBP. This is what the incentives or the payments are based on. It is not an assessment of their whole system. Oftentimes, states use a variety of measures and measure sets to look at the quality of their overarching system. But again, it's about looking at this perspective of what are we creating the incentives on? What do we want to promote, and what do we want to pay on as a system? And those are sometimes a little bit different. They're the same. It's a subset of the overall quality oversight. For Tennessee, the MCOs track health home performance on quality and efficiency metrics. The high-performing health homes are eligible for outcome payments if they, of course, improve quality. And the MCOs are responsible for producing quarterly cost and quality performance reports for the health homes. So the MCOs and the health homes work in tandem and in partnership. Next slide, please. So now we're at the future of VBP, or the present of VBP, depending on how you look at it. On September 15, 2020, CMS released the State Medicaid Director Letter 20-004. It's a pretty lengthy letter. It's very interesting. What it does is it reaffirms the HCL LAN framework, which is the alternative payment framework that I just went through in the slide deck. It supports opportunities to expand VBP in Medicaid, including within fee-for-service, which is a great expansion. It identifies ways that states can support the shift to VBP, including innovative payment strategies. And what's interesting is the work that of the IEPs, and I mean IEPs because the IEP process has been going on for a number of years, actually informed CMS's guidance. So as part of being part of the process, at least for OPWDD and DOH, allowed us to get a lot more information and understanding of where CMS's guidance was going, how it was going to support VBP, and that we were right on the correct trajectory for beginning to think about how to incorporate VBP in the IDD landscape. I think, next slide, I think that concludes my slides. And Roger, I will turn it over to you in terms of time, if we have time for questions or chat, or how you'd like to move on.
Absolutely. I think I managed to successfully unmute myself, which is always a great achievement. So having done that, I am going to first ask members of the panel of the JAC if they have any questions or comments. We can always pivot back to other presentations or other discussions that occurred.
Hi, Roger. This is Michelle. I can't seem to raise my hand today.
Okay.
Tamika, could you tell us a little bit about one of the early slides said that one of the things that you had an opportunity to learn something more about was the stakeholder engagement process. Could you speak a little specifically to what was learned around that?
Yes, I think one of the things that we have been doing, and this is more internal work in OPWDD, and Allison, if you're still on the call, please feel free to weigh in, is really understand how to communicate effectively the various initiatives the timing of communication, how to engage our stakeholders and bring them in the conversation. It's some of the tools that we've used, as well as some new tools like, focus groups, other types of avenues for engaging stakeholders. So I don't know if I answered the question or if there was something more specific you were alluding to.
No, that helped. Was there anything specific from any of the other states that were kind of best practices or things we should be thinking about?
What we did is we worked with Stratus Health, who has worked with other states. So in the process, just like the alternative payment framework, they provided a framework for us to kind of work through, and almost like a workbook of beginning to look at and evaluate how we engage stakeholders. I think it was more of a sort of reflection process and understanding the timing and the approaches that were necessary. I don't know if there was more or less any sort of best practices, other than that their framework is a compilation of best practices, and they have you work through that framework to make sure that you're catching all the underlying concerns, that we understand the perspective of our stakeholders, that we're engaging our stakeholders at the critical point in time as we move through initiatives, and we're doing that in a holistic way, not in a siloed way.
And I can maybe pitch in there something we're talking about, Michelle, as I know you know, but others may not. We did some ongoing stakeholder engagement to try to understand, I think, the most critical and timely question right in front of us, which is, as people know, the Appendix K allowed for certain flexibilities within the waiver that weren't present, but those expire at the end of March 2020, absent further action. So, and that's the maximum extent under current policy for an Appendix K. So we're looking very critically at what was successful, what was successful but could be improved to be more successful, what was not successful in terms of the Appendix K flexibilities. The thinking being, by say within the next month or so, we would need to be submitting something to CMS in order to extend those flexibilities as part of the permanent waiver that makes sense to extend, and those that aren't extended would, of course, sunset. And that's a product of the fact that the maximum extent of an Appendix K emergency waiver is 1 year. So that's this March to next March. So that's a process that has been ongoing through multiple mechanisms. And then what we're hoping to do once those set of questions are answered is to be able to dive a little deeper into some further stakeholder questions. Once again, trying to sequence things in a way that makes sense. So looking, say, early November or late October, depending upon when we're able to complete the work on the flexibilities waiver, to be asking our varied stakeholders how we vision the system kind of moving forward more in the medium term. And that is something where I think what we learned about, it's always good to have somebody kind of take a look at what you have been doing. Clearly you do the things that you believe are going to be helpful and useful, or else you would do other things, and then to kind of give us some critical eye on that. So I think it's more about taking this, what we've done, say, traditionally or more recently, taking a critical eye at it and saying, are there areas where we can do this better? So that's kind of the effort there. I see in the chat box some questions around benefiting from the FIDA experience to help inform larger programmatic transitions with respect to managed care. I don't know if either Tamika or Allison, you want to try to address that question, or is that one I know that we are taking a critical look at the FIDA experience so that we benefit from that trial run, if you will. as we look at the broader initiative. I don't know if there's anything more specific that would be worth mentioning in response to that question, or questions. There's several of them in the chat box as I look down.
No, Roger, I don't think there's anything further at this point, other than we were really looking closely again at, and I think PHP did a great job in presenting at the clinical advisory group that we had some months ago, explaining some of the challenges with measurement. And again, Department of Health was there, OPWDD, and all the participants on the CAG, and understanding some of those lessons learned, as well as opportunities to enhance, the way we look at quality measures. So I think we continue to look at that expertise and look at that experience to determine where we go next. And I think we're going to be doing that more as we move forward with the CAG.
And I see a request from self-direction stakeholder that we engage them in looking at potential VPV approaches as they would apply to HCBS services before we would float such proposals. And I think that makes all the sense in the world. What our thought is that we would be benefiting from the analysis that was given to us. We would be, to the degree to which it's worthwhile to explore those approaches as part of the next iteration of our HCBS waiver conversation. We would absolutely intend to engage as many stakeholders as we can to try to see what proposals have merit and which ones have, less. So, Arnold?
Hi, this is Susan Newell. I have a question.
Hi, Susan.
Hi, Roger. I'm curious about equity, a discussion of equity that appears on the first slide, and what is meant by that in this context.
I'm sorry, I apologize, which slide were you referring to? I just want to make sure I'm.
One of the first slides talks about equity, and I want to know what you're thinking of in that regard.
I think, and Roger, you can definitely weigh in here. I think when we're thinking about equity, we're thinking about not only the ability to access services, but to ensure that individuals who have a disproportionate impact related to access to services or health outcomes are also being served. So I think it's both a combination of everyone having services that meet their needs, but also making sure that individuals who have maybe disproportionately been impacted also are taken into account.
Yeah, and Susan, I can maybe articulate on that. We've talked in different forums about, we've had them in sort of a different order in different places, but sustainability, equity and access, thinking about those as themes that kind of guide really any system of public support. So sustainability meaning, not spending that, more than you have, right? Or not spending more than you might reasonably have in the future so that the system is sustainable. Equity, we've tended to think about as more of a distributional idea, which is to say those who are comparatively more needy would have greater command on resources than those who are comparatively less needy, so that, you have an equitable distribution of the available resources. And then access, once you've kind of figured out what do you have, what's a reasonable distribution of the resource across taking into account need, then access is making sure you have a system that quickly and efficiently gets those services to the people in a way that that helps them and is meaningful to them. And so, so we've looked at a variety of issues through that lens to try to, enhance each one of those. So I hope that's helpful. So equity we've tended to kind of use as a distributional lens, right? People who are more needy ought to command more resource than people who are relatively less needy. Does that help, Susan?
Yeah, so Roger, does that analysis encompass identifying and addressing disparities based on race and ethnicity, for example? Or how will that be looked at?
It certainly could. The contention is that equity, when you're talking about publicly funded supports that are meant to sustain individuals with developmental disabilities and leading meaningful lives, the relevant consideration, and when you're trying to determine access to resources is, what types of supports predicated on need does that individual require in order to, achieve those life outcomes? So there, other types of characteristics of the individual besides the need for support would and couldn't, should not be relevant to that determination. And obviously to the degree to which there are confounding factors that might include race, ethnicity, gender, et cetera, class, one would look to combat those components and have them not implicate the distribution of resources. So I'm looking at a few of the, I just want to make sure. Josie, am I missing any hands?
Roger, this is Arnold. You had called on me there a minute ago. So whatever. Yeah.
Thank you, Arnold. I knew I was missing something.
That's all right. So I struggle to get this question out. So just bear with me a second. So at least one of the states had linked value-based payments, I think, to healthcare savings. So I'm just curious how much you've thought about, I guess, healthcare savings versus healthcare outcomes. So many people served in the system, have chronic either health or psychiatric conditions. So in a way, their healthcare costs may not be able to be managed, even if their program supports are really still of quality, I guess, let's say. So, and I just worry that if healthcare savings becomes a measure coupled with the recent reduction in retainer payments, that it could really incentivize cherry picking and really a preference for not serving people with either significant psychiatric or chronic health needs. So I don't know if I made that question clear, but if I did, maybe you could answer.
I think it's clear, but I'm not sure that I have an answer. I don't know whether Tamika or Allison, or is that a question? I think what you're talking about, Arnold, is to the degree to which certain costs are unavoidable as opposed to avoidable, then inclusion of those costs as part of the value-based payment structure might disincentivize serving higher need individuals. Did I get it more or less right?
Yeah, absolutely. Right.
Yeah, so I think that can certainly be addressed through benefit design, and I also think that well, let me ask Tamika, do you have a response to that? It's a good question, and I don't want to have some thoughts, but I'm not sure they're at all accurate or thought through. Or should we take that one back and maybe try to address it?
Oh, Roger, we definitely need to take that one back. As I mentioned, Arnold, and that's a very, very good question. The intention of our IAP experience of what we intended and what actually happened were two different things. One of our goals initially was to do some financial modeling and looking at quality measures and trying to identify certain types of simulations on approaches that the state could use. We didn't get to that point in our IAP simply because of the public health emergency. And we're hoping that as we move forward, we can take some of the initial, I wouldn't even say it's thinking, some of the other state experience and approaches that we've been formulating and take that back and begin to, sort of identify opportunities to move forward. So unfortunately, we didn't get there yet, but I understand your question and the need to sort of make sure that one is not being sacrificed for the other. We don't want to focus on savings and sacrifice outcomes, but we also have to make sure that as we look at outcomes, that the system still remains sustainable and we're looking at it again in a more comprehensive way. So I understand your question. I think we just need some more work on that.
Thank you.
Okay. I'm looking at the chat line. There are several comments that I think are looking for information. So there's information being sought around 3 items. One, I think the Deloitte analysis regarding costs, and there was a point that that Texas had published some Deloitte information and requested that we do the same. There was a second regarding the FIDA, any analysis of the FIDA program, and the third having to do with Optimus, which is a consultant to OPWDD to assist with what's called the resource balancing model. So none of those are, I think, questions, but more requests for information that we can certainly take back and see what can be shared. And then I have a note that there is a request that at the next JAC meeting that we include information about the DOH, OPWD, and potentially other state entities' rules with respect to oversight. And then I see a follow-up on several comments on the conflict-free care coordination and the relationship between that and managed care entities. So I think I have captured everything in the chat box, but certainly to the degree to which we haven't fully captured everything, we'll endeavor to do so. Let me give an opportunity for the any panel members who haven't had an opportunity or would like to share further information or comment or question. Sounds like the answer to that is no. I'm just going to give it a couple more beats in the event that somebody is struggling to get themselves off of mute. So that being said, I think we will draw this meeting to a close, and we will provide some information about where the materials may be found. Apparently, we need to create the link and then send it out, so we can't post it into the box. But I believe at some point in the meeting, we had a post of how to join our listserv. For those who are not part of it, we tend to distribute out materials through that way. So we'll try to do that. And I wish everybody a safe and healthy day. Be well.